what happened? So what happens is that when the cell is under stress, it's going to start acting up. Okay, now the stress wasn't meant to be there. Now the stress came all of a sudden, and the cell is now going to follow this pathway of necrosis. So the cell, everything the cell is doing, all the functions will first stop. Everything will stop, and all the channels and the ions, the sodium potassium ATPase, the sodium calcium cotransporter, the potassium transporter, everything just stops working. And the channels, they become open. Okay, they're going to open up, and they're going to allow water to rush into the cell. And when water rushes into the cell, what starts happening is that the cell starts swelling. It will swell and get bigger, and all the organelles will accumulate water. The endoplasmic reticulum, the mitochondria, the nucleus, everything will get bigger. And now let's say the stress is removed, the infection resolves, or anything that was causing stress and injury to the cell, it's removed. Once it's removed, the cell can recover. Now, if the stress persists, the infection persists, the injury persists, what happens is that this cell progresses down, and it will further deteriorate, and it will eventually burst. Because there's so much water inside, it will eventually burst, releasing all its contents into the environment, releasing the enzymes, releasing the whatever is accumulated inside it's just going to release. And the body is going to sense that there is some abnormality. Why are there enzymes? Why are there lysosomal enzymes? Why are there mitochondrial enzymes? So it will send a signal, and your immune system will get activated, immunity will kick in, and inflammation is going to start. Okay, this is necrosis. Now, for apoptosis, we said that this was an orderly cell death. This is a programmed cell death. Things are happening in an orderly fashion. Now, what will happen here? The cell is meant to die. It's lived its life. It's lived its function. It stopped working. We don't need it anymore. So everything will shrink. It will shrivel. The chromatin, the nucleus, it will kind of grow smaller. The nucleus will dissipate. It will basically disintegrate into fragments. It's also called karyorexis. And the membranes of the cell are going to come apart, and it's going to form these bodies called apoptotic bodies. Okay, so apoptotic bodies are basically like the cell is just going to fragment, and it's going to contain the enzymes and the lysosomes inside this like ball basically, and it's called the apoptotic bodies. And eventually phagocytes, or like macrophages, they're going to come, they're going to phagocytose these apoptotic bodies, and that's it. That's the end of the cell. So just a quick recap, let's quickly differentiate between necrosis and apoptosis. So necrosis, we said, is accidental. It wasn't meant to happen. Programmed death is apoptosis. It was meant to happen. For example, with RBCs, after 120 days, they're meant to die. That is programmed. Necrosis is reversible, whereas apoptosis is irreversible. We saw that at one point, necrosis is reversible till the swelling, and once the cell ruptures, that's it. From here on forth, it's irreversible. But for apoptosis, it's irreversible. Once the cell is going to die, it has to die. And necrosis, it affects, since it's abnormal, when the cell bursts, it releases its contents into the surrounding, it affects the other cells. The enzymes of the cell, the necrotic cells, it gets released, and it starts attacking and starts affecting the surrounding cells. And when inflammation kicks in, inflammation also damages the surrounding cells. So necrosis happens over a large area, whereas apoptosis, it happens in just one cell. Like one cell in the intestine just dies, or one red blood cell dies. It's not a bunch of cells dying. Necrosis, we said that the cells and the organelles, they swell, whereas in apoptosis, everything contracts and shrivels. And we also spoke about this, that there is a loss of intracellular environment in necrosis, and the cell just ruptures, it bursts. Whereas in apoptosis, the environment is maintained, and the cytoplasm is packaged into these like little tiny spheres kind of thing, and those are called apoptotic bodies. Okay, so here's a question. This is the first question. So I want you guys to answer in the chat, And then I'll ask one of you to unmute and explain. So which of the following is a characteristic of necrosis? Okay, so I'm gonna give like a few minutes for everyone to answer because I'm only seeing 3 answers so far. So, okay, perfect. So yeah, the answer is C. Now I want any of you to kind of unmute and explain why it's C. Anyone, come on, guys. There's no, even if you don't know the answer, I'll just help you. It's okay.
There is a leakage of content. The organelles swell and burst up. So there is a leakage of content, which is eventually called necrosis.
Yeah, exactly. So the reason why organelles they swell in necrosis is like I mentioned, the channels they stop working, the ions they stop working, no sodium potassium exchange, no calcium coming in, nothing is happening. Everything just opens up and allows water to come inside. The sodium comes inside, water comes inside along with sodium, and eventually the cell swells and it bursts. The rest of the options are more for apoptosis than necrosis. Okay, now let's talk about apoptosis. So we mentioned apoptosis was programmed cell death. These cells are supposed to die. They're headed down the pathway of destruction. So cells can die through apoptosis through two mechanisms. Either there is physiological death, like that's what was meant to happen, or it could be pathological. So some abnormality happens and the cells undergo apoptosis. So first, a very important cause of a physiological cause of apoptosis is during embryogenesis or fetal development. So when the fetus is developing, they have webbed fingers, which means that they have a skin flap between their fingers. So the fingers are kind of connected. And through apoptosis, the skin flap it breaks down and it is removed. And that is how the fingers become separate. Now, if this process is affected, then you have fingers that look like this. So you see those two fingers are connected. They're not supposed to be connected. This is abnormal. So through the physiological process of apoptosis, our fingers are separate. Another example is during breastfeeding, there's a hormone that is released to produce and release and secrete the milk, the breast milk. Now, as the baby grows older, they don't want the breast milk. They don't require breast milk. They have to have solids. So they wean off of the breast milk and they go onto solids, which means this process is called weaning, when they switch from breast milk to solids. And so the demand of breast milk goes down. And so the hormone that produces the breast milk decreases as well. It goes down. And when the hormone goes down, those cells that were being stimulated because of this hormone, they are no longer being stimulated anymore because the stimulus is removed, the hormone is removed. So these cells, you don't need them anymore. You don't need this breast milk to be produced. So these cells, they shrivel, they die through apoptosis. Okay? Oh, and the same concept applies to castration. So when you castrate someone, in males, what you do, that means you make them infertile. You remove the hormone testosterone. You remove it. You take it away. You make them infertile. So when that happens, all the cells in the prostate that respond to testosterone, this hormone, they are no longer responding because the hormone is not there. Testosterone is not there. So these cells, the prostate cells, they eventually die through apoptosis. Okay, now there are certain cells in the body, like the skin cells, the GI cells, that are continuously replicating. The old cells are being replaced by the new ones come and replace the old cells, and this is a continuous process. Okay, regeneration. Your skin regenerates the same way. So how does this happen? The old cells, they die because of apoptosis, so that the new cells can take over and replace them. Elimination of self-reactive lymphocytes. So when lymphocytes are produced, you have to check if they are reacting to your own cells or not. If they don't react to your cells, then they're released in the bloodstream. If they react to your own cells, then they are killed, okay, through the process of apoptosis. All right, and lastly, when red blood cells, the neutrophils, they have lived their function. That's it. They're no more required. RBCs have a lifespan of 120 days. So when they're no more required, they undergo apoptosis and they eventually die off. Now, pathological causes. These causes are basically like something is wrong, okay, but not wrong enough for cell to die all of a sudden, just wrong that your body starts killing the cells. Your body tells the cells to die. So first and foremost, common cause of pathological apoptosis is when someone gets cancer, the two main treatments that we offer them are radiation and chemotherapy. So radiation and chemotherapy, they target the cell's DNA structure and they damage the cell's DNA. Once the DNA is damaged, the cell can die. So that is a cause of pathological apoptosis. Another cause is misfolded proteins. Okay, so there are certain diseases in the body. I think you've heard of them. Alzheimer's. It's very common in old people, or amyloidosis. So these two diseases. There's several more, but these are the most commonly known. They result because of accumulation of abnormally formed proteins. Now, what does that mean? When proteins are formed, they are formed in a long chain of amino acids. Okay, it's a very long chain. And then you have to fold it. You have to fold it to make it compact, to make it narrow so it can fit into the cell. Now, sometimes what happens is that when you fold these proteins, they get folded in an abnormal way. And when they get folded, they start accumulating. And the body detects this and it tells the cells, okay, you must die because you have a defective protein, so you must die. All right, and oops. Okay, one other way is when the cell gets infected. So with HIV or adenoviruses, there are certain viruses that go inside the cell. They use the cell's machinery. They make the cell work abnormally. So the body detects this and the body tells the cells to die. Duct obstruction. So when, for example, most common example is the gallbladder duct. When it gets obstructed, then the gallbladder, it shrinks and it shrivels and the cells die. All right, so question. Right, so which of the following is a physiological cause of apoptosis? I want you guys to write your answers in the chat. Okay, more answers. Okay, I see someone saying that you haven't taken this. So do you mean you haven't taken the lecture? Because if you haven't taken the lecture, then I will take a different approach. If you haven't taken that topic that I was teaching, that's fine. Though I was just building on something. So if you can clarify in the chat, that would be great. Have you guys taken the lecture? Okay. Okay, yeah. So what you thought that you didn't take, I was just building onto something. And it will make sense as we progress. Okay, so it was important for me to mention those things. Okay. Yeah, so the answer is D, and I'll explain this since I see someone saying that you haven't taken this in the lecture. So the answer is D, and someone also said A. The reason why it's D is because when in castration, when you take away the hormone, the cell naturally dies, okay? In A, there's a DNA damage through radiation. So there's radiation, there's a pathological cause going on. Something is wrong. There's radiation that damages the DNA and it causes the cell to die. And all the rest of them, they are all pathological causes of apoptosis. Okay, now moving on to the biggest chunk of the lecture, the immune system. Okay, so the immune system is basically, you can roughly divide it into two parts, the innate immune system and the
Hiba, please.
Immune system. Okay. These cells all the time present. So right. So I'm gonna talk about the slide again. So there are two main branches of the immune system. We have the innate immune system and the adaptive immune system. The innate immune system is basically it's naturally there. It's present all the time. Okay. The cells of the innate immune system, such as the neutrophils, are always there in the blood. They're scavenging in the tissues. They're looking for anything wrong, anything foreign to attack. As for the adaptive immune system, it gets activated after the innate immune system gets activated. It is very, very, very specific, okay? It takes a while to get activated. Now, the innate immune system has mainly the neutrophils, and the neutrophils, they comprise about 60 to 70% of all the white blood cells in the body. They're the largest population of WBCs, and the monocytes are part of your adaptive immune system. Okay. All right. Okay. So now let's talk about the steps of the immunity. What happens? Okay, this is just a general overview, and we're going to dive deeper into each step. So first of all, a pathogen enters your body. Okay, a bacteria, a virus, it could be anything. What's the first thing it comes across? The physical barrier. So your skin, your glands, the tears in your eyes, the acidic part, the acidity of the urethra, certain parts of your body, membranes, secretions, all these make up the physical barrier. Why do you tear up when something goes in your eye? Because that is part of immunity. Okay, so your physical barriers are the first line of defense that the pathogens come across. Second is the innate immunity. Now, let's say they are able to breach the physical barrier. They are able to breach the skin. They're able to go past your eyes. They're able to go up the urethra. What happens next? That is when your innate immunity kicks in. So this is triggered when pathogens, they evade the physical barrier, as I mentioned, and they have certain innate immunity has your neutrophils, your monocytes, your macrophages. All these cells, they get activated when they identify a foreign body and they start attacking it. And last thing to get activated is the adaptive immunity. This takes a little while to come into action because it's dependent on the innate immunity. So mainly your T cells and your B cells are part of the adaptive immunity, and they get activated once the neutrophils and the macrophages get activated. Okay. All right, so now we're going to talk about the innate immunity. So innate immunity is very non-specific, okay? Like I said, you have neutrophils, macrophages, everything is there, no antibodies are produced, the cells are there, and they're just going to attack. It's very non-specific. And this kind of immunity is present at birth, and it persists throughout the life. Adaptive immunity is developed later on. So like I said, adaptive immunity is dependent on the innate immunity, and not just that, but also through vaccinations. So when you vaccinate someone, you are activating their adaptive immunity. The innate immunity is always there, okay? And they mainly comprise of phagocytic cells. So I really want you to focus on the phagocytic cells part. Phagocytes are your neutrophils, your macrophages, your dendritic cells. These cells basically, they identify the pathogen, they target it, they engulf it, and then they destroy it with their enzymes and their whatever is like their mechanism of killing. We're going to get into that later. And innate immunity is activated through two very important proteins. So I really want you to focus on this because we are going to talk about it later. The PAMPs and the DAMPs. So what are those? So when a pathogen comes into the body, anything, whether it's a virus or a bacteria, it has its own proteins, right? Our cells on their surface have their own proteins called the antigens. And our body identifies these antigens and says, okay, these are self-antigens. This is my cell. The body identifies it and says, this is my cell. When the body identifies a bacteria through the proteins on its surface, that protein is called PAM, pathogen associated molecular marker. Now you might be saying, why is there a P? So markers can be replaced with hold on. Markers can be replaced with pathogen associated molecular. There's the P stands for something. We're gonna get into that later. I'm so sorry, I'm having a mind block, but the P stands for something. We're gonna talk about it later, but basically it's the same thing. It can interswitch, okay? And damp is when the cells, when they get damaged, our body cells, when they get damaged, they release damp, okay? Damage associated molecular markers. And through PAMPs and DAMPs, the innate immune system gets activated. Okay, now let's talk about the cells of the innate immune system, your phagocytes. Now the phagocytes are, like I mentioned, the neutrophils, the macrophages, the dendritic cells. So the neutrophils, they recognize your PAMPs and your DAMPs. And they go to the site where the PAMPs and the DAMPs are, and they ingest the bacteria and they kill it by proteolytic enzymes. Proteolytic enzymes are enzymes that break down the proteins, and ROS, reactive oxygenated species. They cause oxidative damage to the bacteria, to the cell, causing it to die. Now, macrophages. Macrophages are very similar to neutrophils. They have the same mechanism. They identify PAMPs and DAMPs. They ingest the bacteria. They kill it by proteolytic enzymes and reactive oxygenated species. The only difference is that they also produce cytokines, okay? And they act as antigen presenting cells. What does that mean? They take the antigen, they take the bacteria, they take the protein, they put it on their surface to activate other cells, okay? So that's how they're called antigen presenting cells. They will activate other cells. And lastly, dendritic cells, they act exactly like macrophages, okay? But they kind of act as kind of like a link or a bridge between the innate and the adaptive immune system. And they activate the T cells and the B cells in the lymph nodes. Okay, here's a recap of how the macrophages and the neutrophils function. You can read this on your own. This is not a very important slide. This, however, is a very important slide. So once the macrophage and the neutrophils, they phagocytose a pathogen, what happens next? What happens inside the cell? Now, there are two things that can happen. Either the bacteria or the pathogen is destroyed through enzymes, so lysosomal enzymes, or they are destroyed through the NADPH oxidase, phagosomal NADPH oxidase. So what's the difference? So the lysosomal enzymes, lysosome is an organelle that's present inside the cell. It has destructive enzymes. It has proteolytic enzymes. These enzymes, they break down the protein, the core structure of the bacteria. Whereas for the phagosomal NADPH oxidase, these are basically, they produce hydroxyl radicals. They produce radicals, free radicals, which cause oxidative injury. They use oxygen to cause an injury to the pathogen. This pathway, this right here, this pathway also produces myeloperoxidase, this enzyme right over here. And so if you notice, when you have like an upper respiratory tract infection, if you notice after a few days, your sputum it's going to go green, right? So why does it go green? It's because of this enzyme myeloperoxidase, and neutrophils contain high amount of myeloperoxidase, and all that it does is that it just breaks down your pathogen. That's all that it does. That's all you need to know. But you need to know that the myeloperoxidase has the heme pigment, or the green pigment, which gives the greenish color to pus, to sputum, when you have an infection. And it produces HOCl, which is a powerful antioxidant. It's also found in bleach. Okay, now macrophages, as I said, are present all over the body. Okay, they're not just inside the blood, they're all over the body, in every single tissue. So when the macrophages are present outside the blood into the tissues, they are called sentinels. Okay, what are they called? They're called sentinels. It's not as complicated as it sounds. So now let's take the example of the brain. When macrophages are present in the brain, they change their name, and the name becomes microglia. Okay, don't get overwhelmed by all these names. All you need to know is that all these are macrophages, except when they go into the different organ, their name just changes. And if you see, their shape pretty much stays the same. They do the same thing. They scavenge, they identify PAMPs and DAMs, they go and they phagocytose the bacteria or the pathogen. They have the same function, but it's just that their names change. So in the brain, there are microglia. In your small intestine, there are intestinal macrophages. In the eyes, they're intraocular macrophages. So in the liver, they're called the Kupffer cells. So they just change their names, okay? Okay, now we talked about the phagocytic cells. Now let's talk about those cells that do not phagocytose. What are those cells? So number one, you have the NK cells. The NK cells, they use perforins, which are basically enzymes, and they poke holes in the target cells. And once they poke holes in the pathogen, they release their granzymes, or an enzyme which causes apoptosis. Eosinophils. Eosinophils, they kill parasites, and they kill parasites through the same mechanism, by forming holes. And lastly, we have mast cells that are also part of the innate immune system. They release histamine and heparin, and this is also responsible for stimulating an allergic reaction, okay? All right, so a question. Macrophages utilize which of the following mechanism to kill a pathogen? Answers, guys, come on. I know it's at the end of the day, and I know that we're tired, but let's quickly get this done with. Okay, perfect. Yes, B. So I'll explain why. So macrophages, they use the reactive oxygen species, or the ROS, and they cause oxidative damage to the pathogens. A, this is for NK cells and eosinophils. C is for mast cells, and D, we really didn't talk about this. So yeah. Okay, now let's move on to the complementary pathway. Yes, macrophages also use the lysosomes, yeah. But ROS is one of the ways that they also kill. Okay, so now let's talk about the complementary pathway. So for the complementary pathway, the main aim is that there are several proteins that need to be activated, okay? So when the antibody in the blood gets bound to the antigen, which is present on the pathogen, they form a complex. This complex is called the antibody antigen complex, and they activate the complement proteins. Now, complement proteins, they're just proteins that get activated. It's like a cascade, you know. One activates two, two activates three, three activates four, and eventually the target is to activate MAC, membrane attack complex. And we'll talk about what membrane attack complex does. So the main goal is to produce a few things, opsonins. Opsonins are basically, they're proteins that bind and stick to a bacteria, and they target the bacteria, they tag the bacteria for phagocytosis. Anaphylactoxins toxins are basically your complement C3A, C4A, C5A, and they promote inflammation. Okay, they just cause more inflammation. Next, you have the chemoattractants. The chemoattractants are your complement C3A and C5A, and they recruit more neutrophils to the site. And lastly, like I mentioned, we have the membrane attack complex. So the membrane attack complex is formed with C5b, C6, C7, C8, C9. These 5 complements, they come together to form the MAC, or the membrane attack complex, which goes and pokes hole in the bacterial cell wall, causing it to basically die. So this is what it looks like. You don't need to know in details at all, so don't worry. All you need to know over here is that the complements is like kind of like a cascade reaction. 1 activates 2, 2 activates 3, 3 activates 4, and eventually all of it comes down to activate this membrane attack complex, which causes cell lysis. Okay, so this is an overview of what happens in the immune system. This is your physiological barriers. Then the pathogen goes through the innate immunity, and lastly, it goes through the adaptive immunity. Okay, now one question. Which of the following complement proteins form the membrane attack complex? Any more answers? Okay, so to save time, yes, the answer is D. That is correct. Right, so the answer is D. A is anaphylactoxins, B, chemoattractants, and C are opsonins. So here I'm gonna pause and ask you if you guys have any questions before we move on to the next part of the lecture. No. The exam won't ask a question like that. That's a simple question. The exam would ask something like I asked you previously. That was a very easy one. The whole idea was for you to know what MAC is. The exam would have different questions. I think there's the lecture coming up, the recap, the recall questions, where they're going to summarize all the questions and like kind of give you some examples. That's what it's gonna have. Okay, can I name the phagocytic cells again? Okay, so we have 3 cells that are phagocytic cells, the macrophages, the neutrophils. The neutrophils are the most common, and we have the macrophages. And lastly, we have the dendritic cells. Okay, so we'll start with inflammation. Now, what is inflammation? So inflammation is the initial response of the body to infection or trauma. Whenever there's an injury, there's an infection, the first thing that happens is an inflammation. Now, what are the common signs of inflammation, the clinical signs of inflammation? These are very important. So this is what you may get in your exam questions, especially in SAQs. So first of all, you have rubor or redness, which is increased in vasodilation and blood flow. So the blood vessels, they dilate, they become big, there's an increase in blood flow, and there is redness in the area. That's called rubor. Then you have heat. So this is by the way, in order of sequence, okay? Then you have heat. So because there is like dilation, there's increase of blood flow in a certain area, this causes respiratory burst of leukocytes and macrophages at inflammation site, and this causes the area to become warm. Okay, next there is swelling or tumor. This happens because everything leads back to, by the way, the first point. There is vasodilation, the blood vessels, they dilate, the fluid comes out of the blood vessels, and so it forms a swelling. Then you have dollar or pain. What that means is that because there are certain chemicals that are released at the site of injury, such as prostaglandin, histamine, bradykinin, serotonin, they act on your nerves and they cause pain. And lastly, there is loss of function of that area. Okay, so I want you to recall anytime you got injured, and when you're in the exam, you can't think of the steps, you can't think of it. Just recall anytime you got injured. You, I don't know, hurt your finger, you got a pimple, or you hurt your knee, anything. And this literally happens: redness, heat, swelling, pain, and loss of function. Okay? All right, so the reaction of blood vessels to trauma leads to the accumulation of fluid and leukocytes in the extravascular tissue, so outside the blood vessels. This basically destroys and it dilutes the pathogen because there's water coming out, and eventually it initiates the repair process and everything just like goes back to normal. Okay, so the components of inflammation are basically two things. Two things play a role in inflammation. You have the vascular structures like your blood vessels and the cells. So what is a job of what is the job of the blood vessels? Basically, they cause the vascular reaction. They dilate, they become more leaky, they allow more cells to come out, they allow more fluid to come out. Okay? And when that happens, you have a cellular reaction. Neutrophils come out of the blood, macrophages come out of the blood. So this is called the cellular reaction. And it's controlled by chemical mediators because it's very important to control the inflammation. If it gets out of control, then it can cause destruction. So controlled by chemical mediators such as plasma proteins and cells inside and outside of the blood vessels. So this picture kind of recaps all that I mentioned previously. Here's a pin. You poke a pin in your finger accidentally. This causes PAMPs and DAMPs to be released. Bacteria, they release PAMPs, and the cells, they release DAMPs, the damaged cells. Okay, this will kind of trigger an inflammation. It will trigger the blood vessels to be more leaky, more neutrophils, more cells will come to the site. It will cause swelling and redness and warmth. And eventually phagocytes will come, they will phagocytose the dead cells, the pathogens, and all will be good. And then this wound will heal, and it will either form a scar or it will just heal normally. Okay, so how can inflammation be harmful? So inflammation can be harmful in several ways. In a hypersensitivity reaction, it could basically be a reaction to insects and drugs and insect bites, certain anything that you're allergic to, certain foods. They all cause hypersensitivity reaction. Okay, they cause inflammation all around your body. Chronic diseases are also example of prolonged abnormal inflammation. Collagen, it releases chemical mediators. They attract WBCs and they cause a prolonged inflammation. So anything that is out of control in the body, anything that is absolutely going crazy, that is abnormal. Okay, so inflammation, when it's not controlled, when it's not maintained, it can become harmful. So it can also cause disfiguring scars. So what happens when you cut yourself? You know, the normal way is that it would heal without forming a scar. But when inflammation basically increases and it prolongs, it causes the buildup of scar and collagen and fibrotic tissue, and it leads to scar formation. Okay, moving on to the next slide. So let's compare basically the acute inflammation versus chronic inflammation. So basically different types of inflammation. So acute inflammation is shorter. All right, it occurs and it finishes. Some have a time limit. Some books say less than 2 weeks. Some say, oh, there's no time limit. But basically, it's shorter. It's predominated by neutrophils, and it is finished very quickly. It starts quickly and it finishes quickly. Chronic inflammation is longer. Okay, and here is where it's predominated by macrophages and by lymphocytes. And chronic inflammation, it repairs through fibrosis and angiogenesis, which means formation of new blood vessels. Granulomatous inflammation is somewhere in the middle. it's not really chronic inflammation. It's basically when inflammation is, it's basically a form of chronic inflammation. It's when inflammation proceeds for a very, very long time. It's activated by macrophages, and it has multinucleated giant cells. Don't need to focus on this, just need to know that granulomatous inflammation is a form of chronic inflammation. Okay, acute inflammation. Now we're going to talk about basically what it is characterized by. So it obviously, we said there's an increase in blood flow whenever there is an inflammatory response. The blood flow increases. You have swelling, you have edema, the blood vessels, they become more leaky. There is an increase in hydrostatic pressure, and there's a decrease in intravascular osmotic pressure. What does that mean? So there's an increase in the pressure inside the blood vessel, which pushes the water outside the blood vessels. This is called hydrostatic pressure. And leukocytes, they leak from the blood vessels, they go into the tissues or wherever the injury is, and they accumulate basically at the site of injury. Now, we mentioned that a very important characteristic of acute inflammation is edema. Now, what happens in edema? We have plasma proteins. Basically, they are just proteins that are present inside the cells, and they maintain a normal pressure. Remember, proteins are mainly responsible for maintaining the pressure inside the blood vessels. This is a very important thing, okay? This can come as one of the questions. So what is the most responsible for maintaining an osmotic pressure? It's your plasma proteins. So they draw the fluid that leaks out of the cells. Their responsibility is to draw the fluid back into the blood vessels so that you don't have edema. Now, what happens is when there is a dysregulation, or when there is an abnormality of the hydrostatic pressure, or there's an abnormality in the level of these proteins, more fluid is pushed out. When there's an increase in hydrostatic pressure, remember, when there's an increase in hydrostatic pressure, the pressure inside the blood vessels is increased. Water will be pushed out. When there are less plasma proteins hold the water inside the blood vessels. When there are less plasma proteins, less water will be held inside the blood vessels, and you will have eventually edema. So inflammation causes the endothelial cells to separate. Normally, the endothelial cells are like this. Once there is inflammation, they kind of separate. There's kind of a space between them. So fluid and protein will leak. These plasma proteins will leak out of the gaps in the blood vessels in the endothelial cells. And that will, when the proteins will leak, then water is not going to be taken back up in the blood vessels, and it will remain in the extracellular space. Okay? Is osmosis the opposite of hydrostatic pressure? They're not related. No, there is no relation between them. What is osmosis? Osmosis is basically the calculation, or basically how concentrated or dilute a substance is. It's the number of osmoles present, right? And hydrostatic pressure is basically the water molecules, the pressure that they exert inside the blood vessels. So they're really not, they're not that related, okay? All right, so let's move on to this picture. This is a very nice picture. So this is what is normally happening. This is your normal blood vessels. The cells are connected. There are no spaces. There's plasma proteins inside. Everything is normal. Now, let's say there's an inflammation. There is an injury. Something is happening, and inflammation is triggered. Now, these endothelial cells, as you can see, they will separate. Not only will they separate to allow water to leak, but also to allow the neutrophils and to the cells to leak, to cells so they can go into the site of injury. When they're connected, when the endothelial cells are connected and joined, the cells will not be able to go past them into the site of injury. So when they open up, water begins to leak. Water begins to go outside. But here, as you can see, protein remains inside. So there is a chance of water to come back inside the blood vessels. But in this type of inflammation, what happens, not just the water is leaking, but also the proteins are leaking. So there's no way for water to come back inside. Now, you don't need to know basically what happens, what's transitate, what's exudate. I don't think that that's important for now, but I just wanted you to know the difference that sometimes when protein also leaks with water, then it's hard for the water to come back into the blood vessels. That's basically the takeaway message from this, okay? All right, so now the blood vessels, they start opening up, the endothelial cells, they start opening up. Now what happens? Okay, now leukocytes or WBCs will begin to leave the cells, okay? When they begin to leave the cells, this is called leukocyte extravasation. So the leukocytes, they are delivered from the lumen of the blood vessels into the interstitium, into the tissue space. And once leukocytes are in the lumen, what happens is three things happen: migration, rolling, and adhesion. So migration is basically when the neutrophils or the WBCs, they begin to move across the blood vessels. They can move in two ways. They can migrate in two ways. There's something called the diapedesis and something called the chemotaxis. Diapedesis is when the migration of neutrophil occurs across the endothelium. So I'm going to show you that in the next picture. They're moving across the endothelium of the blood vessel. And chemotaxis is when they move in the tissue. So now they're outside the lumen of the blood vessels. They're no longer in the blood vessels. They're moving inside the tissue. This is called chemotaxis. They're moving within the tissue to go to the site of the injury. Okay, so this is what basically, so this is what it looks like. So there are three steps that I want you to focus on. First, what happens, we spoke about this, there's an increase in permeability, meaning that the endothelial cells, they will separate, they will form kind of like gaps so that neutrophils, they can come out, water can come out, blood flow stops, it slows down, doesn't stop, it slows down, so that the neutrophils they have time to roll across the blood vessel. When they roll across the blood vessel, they will stick to the blood vessel. We'll talk about how they stick in the next slide. So they will stick onto the blood vessel and they will roll, and eventually they will pass through these gaps in the endothelial cells, and this process is called diapedesis. And then through chemotaxis, they will move within the tissue to the source of the infection. So they will go towards where chemokines are. Remember, macrophages, they release your chemokines. Macrophages, remember I said that they release these chemicals which recruits more neutrophils to the site of the injury. How do the neutrophils know where to go, right? How do they know where do I go? Where's the injury? They don't have eyes, they don't have ears. So they go where there are chemokines such as interleukin-1. Wherever they sense that there are chemokines, these chemical mediators are being released here, I must go to that site. I must go there, okay? So that is called chemotaxis. Okay. So this was the process that I was mentioning earlier. So we have the rolling. As I mentioned, the blood slows down enough for leukocytes and for neutrophils to roll against the endothelium, against the blood vessels. Okay, so we have a question. Only macrophages release chemokines? Not only, but they're the main ones who release chemokines. There are other things that release chemokines that they weren't mentioned in your lecture, so I didn't mention them. But yes, they're one of them. Okay, so blood slows down, your neutrophils, your leukocytes, they slow down, they begin rolling onto the wall of the blood vessel. Neutrophils, sorry, they express this marker. Think of it just like a lock and key kind of mechanism, okay? The key has to go inside the lock, okay? So the key here is the CD18, which is this protein that's present on the neutrophil. It locks with another protein on the blood vessel called the E-selectin. So the reason why we have this mechanism in place, this lock and key mechanism in place, is so that neutrophils abnormally will not attach to the blood vessels. Because if neutrophils start attaching to the blood vessels, there's inflammation and blood vessels are going to get clogged, right? So you don't want anything to attach to the blood vessel walls. You want the flow, you want the blood to flow, you want the lumen to remain open. So normally, neutrophils, they will not express the CD18 unless there is an inflammatory process, unless they need to pass through the blood vessels. That is when they will express these proteins that we're going to talk about, so that they can act like a lock and key mechanism. They can open this lock and they can go within the blood vessel. So the CD18, it attaches to the E-selectin. This is through the rolling. Then we have something called tight adhesion. Now, think of it this way. Tight adhesion is basically, they really like jam. They really like stop, and they really stop and stick to the endothelium. And they use these proteins called CD18 and CD11, and they attach to ICAM, which is another protein on the blood vessel. And now they have stopped in place. Now they can be allowed to squeeze past into the tissue between the endothelium. So I know that all these names may be very overwhelming, so don't worry. All you need, I think the most important thing here to know is the CD18, CD11, and ICAM interaction, because that's very important. That's the integrin dependent. ICAM stands for integrin, okay? And here you have the E-selectin, or the selectin-dependent interaction. That is for the rolling. These are the only two takeaway things that I want you to, these are the only 2 points I want you to take away from this slide, okay? And from Dr. Abdul-Jabbar's slide. This is very important. This will come. I'm pretty sure he will bring this. Okay. Now, just to quickly recap, we will quickly recap what we have discussed so far. We said that there is edema, the blood vessels become leaky, they become more permeable, more water, more protein is leaked, neutrophils come in, macrophages come in, and eventually at the very, very, very last, the green bar, the green graph is for adaptive immunity. That is when your T lymphocytes and B lymphocytes, or T cells, B cells will come. Okay, so the very first to arrive at the site of injury, the very, very, very first, are your neutrophils. Within the 6 to 24-hour period, they will arrive. Now, you may ask, okay, so if macrophages are coming after the neutrophils, how do they release the chemokines for the neutrophils to come, right? Now, remember I said macrophages are present all over the body in the tissues. So they're present in the form of sentinel cells. They will scavenge, they will hunt. Whenever the local macrophages, the tissue macrophages, identify a pathogen, they will release chemokines. They will attract neutrophils. Neutrophils will come. Neutrophils will attract more macrophages. More macrophages will come to the site of injury. So 24 to 48-hour period, more macrophages will come. And lastly, you have the activation and adhesion molecules, activation of adhesion molecules, sorry, and chemotactic factors. Okay, so someone asked to explain this picture. I will explain it to you, but at the very end, just so once I finish, then I will explain that picture to you, okay? So they basically want to talk about this picture. They sent me another picture and they want me to talk about that. I will discuss it at the end of the lecture, inshallah. Okay, so we're almost done. We're nearly there. Just hang on, just a few more slides left. Okay, now what happens after inflammation? So I said that anything abnormal happening, when something is left uncontrolled, unregulated, it will lead to abnormalities. This will now become a problem, right? It's not being controlled, it's going out of control. We need to control it. So acute inflammation, as soon as it starts, mechanisms to control it begin. Okay, so what happens at the end of acute inflammation? The infection, the inflammation can completely resolve, right? The infection can go away. Your body, your immune system won, it took over, it killed all the bacteria, plus complete resolution. Or your body responds by trapping the bacteria into an abscess, into a part of the body called the abscess, It just traps the bacteria, forming an abscess. Or it could lead to fibrosis. Fibrosis means formation of scar, collagen, deposition of collagen, and formation of scar. So acute inflammation can also lead to scar formation. It can occur mainly after there is a significant tissue destruction. So the bigger the inflammation, the bigger the injury to the skin is, the more chances it's going to cause a scar. And when scar also forms, don't forget that scar also forms in those tissues that cannot regenerate. So your heart tissue, they do not regenerate. Heart cannot produce more cells. So the dead cells, that patch of dead cells, it gets replaced by scar tissue. Okay, or eventually, the very last point is very important, that it can eventually lead to chronic inflammation. So here is a summary slide, basically talking about everything that I spoke about. There is an injury, there is a bacteria, there is a problem, and it's present in the blood. Now, what happens is that it can either lead to acute inflammation, it can lead to chronic inflammation. If the injury persists, it will progress, the inflammation will progress and lead to chronic inflammation, okay? Eventually, chronic inflammation can form fibrosis, can form a scar tissue, there's loss of function, or none of that happens, okay? There's complete resolution, but no problem, it's fine. The infection went away, the trauma got healed, the injury got healed, sorry, the bacteria got killed, and everything went back to normal. Or it could lead to an abscess formation. So the body traps the bacteria into an abscess and it leads to pus formation. So these are the different outcomes summarized in one slide. Okay. All right. So next question. Mention 4 cardinal signs of inflammation. Anyone? You know, the quicker you guys answer, I'm sorry, there should be 5, by the way. You know, the quicker you answer, the quicker we get done with. So 5 important signs. Good. There's heat. Okay, perfect. There is redness. So redness comes first, then heat, but that's fine. Good job. Then there's swelling. Very good. You're missing 2 more. So when you get hurt, what happens? What do you feel? Excellent. Pain. Very good. And eventually, let's say you twist your ankle. So it's going to go red, you're going to feel warmth, you're going to see it swelling, you're going to feel pain, but then what happens? Excellent. Loss of function. Very good. Good job, guys. Okay. Do you have any questions for me that I can answer before we proceed? Okay, so you can write them in the chat, and from time to time, I do open the chat and I will answer your questions, okay? So chronic inflammation. So chronic inflammation occurs after acute inflammation, obviously. Acute inflammation, I said, it's shorter. If it doesn't finish, if it's left uncontrolled, it can progress to chronic inflammation. So it can cause tissue destruction. And like I already mentioned, it's preceded by acute inflammation or persistent infection. So why do we say that HIV is a lifelong infection? HIV is a lifelong infection because it leads to chronic inflammation. Syphilis, same thing. All STDs are mainly lifelong infections, and that's why they cause chronic inflammation. Exposure to toxic agents, again, lead to chronic inflammation. Autoimmunity, I already spoke about this. When your own cells, they attack your body cells, when your immune cells, they attack your body cells, it leads to autoimmune reaction. So we said for acute inflammation, we mainly have macrophages, we mainly have neutrophils, but for chronic inflammation, one cell that is so important that you will not see in acute inflammation. I want you to memorize this because this is super, super, super important and high yield and will come in your exam, are your lymphocytes. So lymphocytes are part of a chronic inflammatory process, and you will see them in a very less amount in acute, but you will see a lot of lymphocytes in chronic inflammation. So this slide that you see here, purple cells, whenever you see purple cells, purple big nucleus, immediately know that this is that these are your lymphocytes. So in chronic inflammation, you have infiltration of mononuclear cells. Mononuclear cells means cells with only one nucleus. So your macrophages, your lymphocytes, your plasma cells. Polymorphonuclear cells are cells, poly means more. These cells have the nucleus, they have more than one lobe, so your neutrophils. Okay, and tissue destruction is obviously the lymphocytes, the macrophages, they cause the tissue destruction. And eventually there is, if the chronic inflammation resolves, it will cause scar tissue formation, new blood vessels will form, and it will eventually lead to scar tissue formation. Okay, now macrophages in chronic illness. So this is an important slide, sort of. So we're going to talk about how the macrophages come to the site of the illness. So basically, it's exactly the same thing with the neutrophils. So if you understood the neutrophils, you're good. You're good if you understood the neutrophils part. Same thing after the monocytes. So yeah, here's one important thing. When macrophages are present inside the blood vessels, they are called monocytes, okay? When they move to the tissue, there are certain chemicals over there that make them into macrophages. So that's a very important thing to know. Monocytes are present inside the blood vessels, and macrophages is when they become big. Those monocytes, they become big, they become large, and now they're able to phagocytose. Monocytes are not able to phagocytose. So someone's asking me what lymphocyte this is. You can't really tell in a histology picture. You can't tell because you will only be able to tell if you do staining on them, and if you identify the marker on these lymphocytes. That's how you will be able to tell if they're B or T lymphocytes. But just by looking in histology, you won't be able to tell. Okay, I like how curious you are, by the way. That's a good quality. Okay, so macrophages, they predominate the site by 48 hours. We said within the first 24 hours, it's usually no neutrophils, but when after 24 hours, inflammation does not resolve, macrophages start coming in. And then when inflammation progresses and it stays and it maintains and it persists, it will lead to chronic inflammation. So macrophages will come after 48 hours. An activation of macrophages, it results in, like we said, macrophages, when they get activated, what do they release? They release chemokines. They release chemokines to attract more macrophages, attract more neutrophils. So here's what it looks like. This is your monocyte. You can see. Then when it comes into the tissue, it turns into a tissue macrophage, and several factors play into a role, and then it basically gets converted into an active macrophage. And then it does several things: fibrosis, tissue injury, coagulation factors, attracts more neutrophils. There's several roles of macrophages, not the point of discussion here. Okay, now we spoke about the macrophages. What other cells come in chronic inflammation? Like I said, lymphocytes, very, very important, very, very distinctive cell. They produce inflammatory mediators. They participate in cell-mediated immune reaction. They produce antibodies. Eosinophils. Eosinophils are also another type of cells that you will see in chronic inflammation. They are mediated by IgE. You don't need to know what exactly IgE is, just memorize it, that IgE equals to eosinophils. Okay, E. For right now, you don't need to know what it means. It's just one of the immunoglobulins that are released, and they activate eosinophils. Okay, E for eosinophils, E for IgE. And they contain proteins that are toxic to parasites. Last, we have the mast cells. Mast cells, they release, like we mentioned, histamine, cytokines, all these chemicals, basically, that, again, they activate, prolong inflammation. All right. Now, we've been talking about chemicals in inflammation. What chemicals have we been talking about? So these chemical mediators are released through the following mechanisms. So first we're going to talk about how they're released, what they do, and then we're going to talk about what kind of chemicals we're talking about. So how are they released? What causes these chemicals to release? So first off, right off the bat, you can tell me macrophages. Macrophages release these chemicals. You're correct. Macrophages release them. Another thing, infection, pathogens, the identification of pathogens. So there we go. I couldn't remember what the P stood for. It stands for patterns. So pathogen associated molecular patterns. I'm sorry. I forgot what the last P stood out for. Okay, so when the body detects when the body detects these proteins on the pathogen, PAMPs on the pathogen, it releases chemical mediators. Okay. Similarly, when the pathogen or any trauma damages the cell, it brings damage to the cell, it also releases certain substances. These are called DAMPs. DAMPs stand for damage associated molecular patterns. They're released from dead or injured cells. And both PAMPs and DAMPs, they interact with a very, very important receptor that I'm going to talk about. And the next 2-3 slides are extremely important. So I really want you to focus. I think this is like one of the last few important things that we're going to talk about, okay? So your PAMPs and your DAMPs, they activate receptors called toll-like receptors, okay? Also called PRRs. PRRs, they belong to this big class of toll-like receptors. Now, what do the toll-like receptors do? So we'll recap one more time just to make it easy for you guys, because I know it's the end of the day. So when a pathogen enters the body, it will release PAMPs, okay? And when it affects or targets or attacks cells, and there's damaged cells and the infected cells, they will release DAMPs. The PAMPs and the DAMPs will go and bind to a receptor, a very special receptor called the toll-like receptor. Once the toll-like receptor gets activated, let's see what happens. So once the toll-like receptors get activated, now the process of the production of chemical mediators starts. Now we start producing the chemical mediators. Now what starts happening is inside the cell, okay? So the cell detects the can you guys hear me? Is my voice clear? Okay. All right. So what happens is that PAMPs and DAMPs, they are going to go and they will bind to toll-like receptors. Now, toll-like receptors, they will activate a process. Now, NFK is basically this protein that's present inside our cells. NFK is bound to LKB. Now, LKB, this one right here, it is when they're both bound, they're present in the inactive form. Okay? Inactive form. NFK and or nuclear factor kappa B. You don't need to memorize the full name. So when it's bound to this substance right here, it's present in the inactive form. Then then the toll-like receptors, they get activated. So now this complex, this NF kappa B and L kappa B, this complex needs to get activated. Now we need to separate these in order to activate your NF kappa B. You need the NF kappa B. I'll tell you why. So there's something called the L kappa B kinase. This is an enzyme which phosphorylates this enzyme, this complex, to separate the inactive L kappa B and the active nuclear factor kappa B, NFKB. Okay? NFKB is kind of like, think of it like your key. It's the key that you need to unlock this DNA molecule to start the production of chemical mediators. Okay, so I'm going to recap because I know it was a lot. So normally when there is no inflammation, you don't need to produce chemical mediators. The NF-kappa B and the NFKB or the LKB are joined together, and they're kind of like they're silent. Okay, nothing is happening. They're quiet. They're inactive. Then the toll-like receptors, which were present on top of the surface over here, they will get attached to PAMPs and DAMPs. They will sense that there is an infection going on. There's something abnormal. We need to produce chemical mediators. We need to produce these chemokines. We need to attract neutrophils and macrophages. Inflammation needs to start ASAP. So what they do is that they activate this L-kappa B kinase enzyme, which phosphorylates this complex. They separate. NF-kappa B is now free. It translocates to your nucleus and it activates the transcription, translation, and basically chemokines are produced and inflammation occurs. Okay, so these chemokines, they're derived from plasma cells. They bind to specific target cells in the body. They stimulate the release of mediators from target cells. So basically one chemical mediator, it will go and attach to target cell, which will release more chemical mediator, which is going to release more chemical mediators, more chemical mediators. It's like a chain-like reaction. That's how they get activated, okay? They activate many tissues in the body. They have various effects depending on the target cells. So chemical mediators can have different effects. It's not just one effect. And of course, like I mentioned so many times, if something is left unregulated, untreated, it can become harmful. So what are some chemical mediators? So I think this slide, I think somewhere in the transcription, I was reading your batch's transcription, someone said that they're not important. Just go over it anyway and make sure you confirm if it's important or not, because in my time, it was very important. Like we had to know them for the exam purpose. So I'm quickly going to go over them. Prostaglandins, we're going to talk about the different types of different functions of prostaglandins. So they cause vasodilators. There are different names: prostaglandin I2, prostaglandin E1, prostaglandin E2, prostaglandin D2. You don't need to know them. I don't think you need to know them. Vasoconstrictors like thromboxane A2, pain, they also cause pain. They cause fever. This one is important. PGE2 causes fever, okay? Fever is caused by PGE2. Steroids and NSAIDs, they're two medicines that block the production of prostaglandins. Then we have your leukotrienes. The leukotrienes, they increase the vascular permeability. They make the blood vessels more permeable, so neutrophils and water can come out. Then we have, they also cause vasoconstriction. They cause leukocyte adhesion and chemotaxis. Remember, we discussed these terms. Leukocyte adhesion means when the macrophages, they attach to the blood vessels, and chemotaxis means when they migrate through the tissues. Steroids, they block the leukotrienes. Okay, so cytokines, like just last few slides, guys, stay with me. So cytokines are basically, they're proteins that are mainly produced by activated lymphocytes and macrophages. We already discussed this. They modulate the function of other cell types. We also discussed this. Interleukin-1 and tumor necrosis factors, so IL-1 and TNF, they're the major cytokines that you need to know. These two, you really need to know them. IL-1 and TNF, these are the main chemical mediators, cytokines that are released that initiate inflammation. Okay, so chemokines, they're basically just small proteins. They activate, they attract leukocytes. I'm just going over the summary slides, okay? They're just quick summary slides. They stimulate leukocyte recruitment. They cause inflammation. They control the normal migration of cells through the tissues. Other examples are interleukin-8. We also spoke about them. The interleukin-8 was mentioned in one of the pictures that I want you guys to focus on. Exotoxins, lymphotactin. Okay, and lastly, after the injury, after trauma, after inflammation stops, what happens? We have wound healing. So for wound healing, injury induces acute inflammation. We spoke about this. Parenchymal cells, they regenerate after the inflammation goes away. Then the cells and the connective tissue, they come together to basically produce scar tissue or extracellular matrix. and then there's remodeling that happens, and eventually collagen deposits and the wound is strengthened. So all of this is summarized here. I just included this slide for the sake of completion. There's wound healing by first intention and by second intention. First intention is clean healing. There's very limited scarring, very limited wound contracture. Second healing, there's scarring, there's laceration, there's ulcers. So you just need to know very superficially what first and second intention wound healing is. Okay, and with that being said, that's the end of the presentation. Thank you so much for paying attention, for staying. If you have any questions, I can answer them right now. Any questions? Anything you want me to re-explain? Anything you did not understand? Any confusion? Anything that I didn't answer? Okay. Yeah, just the picture. I remember that. Thank you guys for attending. So I think you guys can stop the recording here. So I can